Good evening, ladies and gentlemen. Good evening, Facebook Live. Good evening, our Zoom attendees. It looks like we just began to broadcast, and there is a bit of a delay between Facebook Live and Zoom. So we'll take a few seconds and allow all the platforms to catch up. But I'd like to welcome you all to the continuation of the AAMS's educational webinar series, which are part of our continuing medical education and continuing dental education programs. For those of you who don't know me, my name is Viken Sepilian. It's a distinct honor to be in front of you today as the chair of the CME committee and as a board member of the Armenian American Medical Society. With me today, moderating this session, is Dr. Rami Apelian. Dr. Apelian is a board member of the organization, as well as the chair of the membership committee. He will be joining us shortly as we enter the discussion and the Q&A session. We have yet another exciting program for you today, a very informative and very important lecture as we learn various aspects of COVID-19 and the coronavirus and the way that it behaves. As we get going with the educational program, I'd like to make a few quick announcements. We've already granted more than 20 CME credits. Dr. Apelian will go a little bit more in detail at the end of the lecture today. But I'd like to make everybody aware of upcoming events. We have another webinar coming tomorrow, and tomorrow's webinar is a very unique one insofar as it's going to be brought to you in collaboration with the Armenian Bar Association. We're going to be talking about some practical issues as it pertains to practice of medicine. We're going to highlight some business law and employment law issues as it pertains to practice of medicine, as well as some of the relief programs that the government has put in place. We're going to talk, we have an attorney tomorrow, Ara Babayan, as well as a banker who will be discussing the PPP as it pertains to our practices and ourselves. Also next week on Tuesday, we have a genetics and a virology lecture by an outstanding faculty, Dr. Wayne Grody from UCLA and Dr. Yevgeny from University of Washington will be joining us next week on Tuesday. Monday will be off as it is a holiday. With that, I'd like to get this program started today. Today, we really are blessed to have Dr. Sarmen Sarkissian joining us. Dr. Sarkissian is a hematologist and oncologist with Pacific Shores Medical Group, their headquarters in Long Beach. Dr. Sarkissian is board certified in internal medicine, completed his undergraduate studies at UCLA, earning Bachelor's of Science in Chemistry. He received his medical degree from the University of California in San Diego and served as his internship and internal medicine residencies at Los Angeles County USC Medical Center. Dr. Sarkissian served his hematology and oncology fellowship at the University of California, Irvine Chow Comprehensive Cancer Center in Orange. His practice focuses on all aspects of hematology and oncology. His specific interests include malignant hematology as well as early phase clinical trials. Dr. Sarkissian is no stranger and has lectured to our audiences and shared his expertise before. And today he will be talking to us on hypercoagulability and various clotting issues as it pertains to COVID-19. With that, Dr. Sarkissian, I'm going to welcome you to our platform please go ahead and enable your video and enable your microphone and take over this Zoom platform.
Thank you, Dr. Sapilian, for having me. I appreciate it. I just want to make sure my video and mic are coming through loud and clear.
Yes, we can see you and we can hear you.
Okay, very good. So, well, thank you everybody for joining. It looks like we have 34 participants. It should be fun, exciting. We're going to talk about a lot of nerdy biochemistry, cell biology, and eventually get into some of the really important clinical aspects of hypercoagulability in this pandemic. So I'll start my screen share and just chime in if there's any technical issues. And we'll get this thing going. All right. So the topic is going to be COVID-19 associated coagulopathy. This is probably one of the newest terms in medicine. It's really just been coined during the last several weeks, and I'll sort of get into the evolution of this. Thank you again for coming in. So let's just do a little bit of a background. Since the outbreak, there's been a growing concern regarding the hypercoagulable nature of novel coronavirus. A lot of case reports and case series started coming out where they noted that as these patients got sicker and entered the intensive care unit, there was a pretty high prevalence of venous thromboembolism, pulmonary embolism, and to a much lower extent, arterial thromboembolism versus sort of age-matched controls, disease-matched controls in the ICU setting. At first, there was also this clinical pattern that was emerging and appeared to be very consistent with DIC. But eventually, as more data became available with open access journals and a lot of the locked journals also allowing their publications to just become public and readily available for free, the data sharing was just amazing, and people were able to figure a lot of stuff out very quickly. At first, the emerging picture was that this novel coronavirus was predisposing patients to developing DIC. But it appears that the phenomenon appears to be a little bit different. So we'll sort of go into some of the pathophysiology behind that. And eventually, near the end of the lecture, we'll talk about where does this information fit clinically for a lot of different subspecialists and what's going to be the role of anticoagulation. So we'll just do a little bit of a background on thrombosis. Going back to medical school, Virchow's triad, the combination of endothelial damage, blood stasis, and the release of procoagulant factors, including fibrinogen, factor 7, a lot of other enzymes released by neutrophils, circulating prothrombotic particles, they all lead to a very hypercoagulable state. So DIC, disseminated intravascular coagulation, is a little bit of a spectrum as far as the phenomenon, but it really is widespread hypercoagulation with the formation of microthrombi in the arterial system. It's most commonly seen with sepsis, followed by cancer, and then trauma and some obstetric complications as well. After an inciting factor, it leads to progressive consumption of coagulation factors, microthrombi formation, and eventually end organ ischemia. Prognosis can be very poor once you start developing microthrombi in your big organs, your liver, importantly, your lung. Management is multifocal. It involves supportive care, both upstream, treating the initiating factor, whether that's sepsis, cancer, whatever the obstetric complication is, and eventually managing the problem downstream. So just a real brief overview of the coagulation cascade. On the left-hand side, we have the intrinsic pathway, and on the right-hand side, we have the extrinsic pathway. We can focus a little bit on the extrinsic. For example, say somebody has tissue injury. That could be from gram-negative bacteremia, releasing lipopolysaccharide. It could be physical injury from a variety of other factors. For example, in CV-19, you are going to get tissue injury in the endothelium. You get release of tissue factor, and it starts this cascade where factor 7 is activated, which in turn converges on factor 10 along with the intrinsic pathway. That activates thrombin, and from there, you get activation of fibrinogen into fibrin, and you start to form the fibrin mesh. And it's in this mesh that platelets start to aggregate, and then you essentially form a thrombus. In normal healthy physiology, this occurs at, unincited injury to an endothelial damage, external injury, internal injury. It's a way of maintaining hemostasis. But in DIC, this cascade is happening everywhere in your body, and it's a little bit of an avalanche that eventually gets out of control and kills the host in which it's occurring. And if you see at the bottom of the slide, as with all other physiologic processes, there's a compensatory mechanism. There's a homeostasis that's engaged, and you get activation of tissue plasminogen activator, and then you get plasminogen and plasmin. And this is sort of the natural fibrinolytic system, which decomposes that clot. Here's another cartoon. These images are borrowed online. The references are all at the back. I did not draw these myself. But if you look at the left of the screen, let's just say you have an inciting event, a bacterial infection. We can think of obviously coronavirus. You get release of numerous procoagulants. These activate a cascade, like I was mentioning, the intrinsic cascade, and more importantly, the extrinsic cascade. And in the center of all this, you have thrombin. Thrombin is what initiates the activation of fibrinogen, converting it to fibrin, and then you get widespread thrombosis, as we can see in that turquoise convergence. And eventually, if you follow the arrow at the bottom, you start with non-overt DIC, and then you enter a thrombotic phase. That's when you really start forming thrombi everywhere. And if this starts to get out of control, then eventually you move to the right of the screen as the arrow progresses, and you end up in a hemorrhagic phase. This is always a bit paradoxical for a lot of people. How can you have thrombosis and hemorrhage? It's not that they're occurring at the same time. You're hemorrhaging because you've exhausted your entire thrombotic mechanism to form any clots. That's generally a very bad point. I mean, if you ever see these patients, they're almost always in the ICU. They could be oozing from their central line or other peripheral IVs, and eventually they can have internal hemorrhage too. Here's a slightly zoomed out view. Cascade initiating event on the left from sepsis. You have pro-inflammatory cytokines. These allow mononuclear cells, such as monocytes, to release tissue factor. It can also happen from endothelial damage as well. This is eventually, again, just reiterating the same point, you get convergence on thrombin, which activates fibrinogen, which breaks it apart into fibrin. You create the fibrin mesh, which you can see is that lattice network, and that traps platelets. And eventually, as it gets more complex, you will start trapping red blood cells, causing hemolysis, and that's where you start to see hemolytic picture as well. So that's the background of DIC, disseminated intravascular coagulation. Some of the laboratory abnormalities we can see, going back to our slide, as you can see with factor 7, as you start to consume factor 7, your prothrombin time will go up. As you start to consume platelets, your platelet level will drop. Eventually, you'll start consuming your intrinsic pathway as well. Your PTT goes up as well. You start consuming more fibrinogen, your fibrinogen levels start to drop, and that's your classic picture of DIC. Elevated prothrombin time, activated partial thromboplastin time, suppressed fibrinogen levels, and suppressed platelet levels. Now, where does this fit into our novel coronavirus? Remember that thrombosis has both the coagulant protein portion, the fibrin mesh we talked about, and the platelet plug. On the coagulation end, again, we're going to think about the mechanism involved. It's going to involve TNF-alpha, interleukin-1, and importantly, interleukin-6. Interleukin-6 was sort of this forgotten cytokine over the last 20 years that really only found a role in a couple of arenas. It was useful in rheumatoid arthritis, as we know Adcentris was developed several years ago to treat RA. It did find a little tiny corner in the world of hematology. There's a really rare disease called Castleman disease. It's actually treated with an antibody called siltuximab. It targets IL-6. They were trying to find ways to improve anemia in myelodysplastic syndrome, where interleukin-6 is highly activated as well. It never really found a role. Interestingly, a few years ago with the development of CAR T, they started to notice that patients developed these giant cytokine storms, and they were able to suppress them and save patients with not exactly IL-6 targeting antibody, but the receptor, the IL-6 receptor. So tocilizumab found a little bit more use, but nothing really too groundbreaking. And lo and behold, when novel coronavirus got hold, they quickly realized IL-1 and IL-6 are very important. And we'll get to some of the data later, but it appears that tocilizumab, if initiated early, can really make a big difference in keeping patients out of the ICU and out of the morgue. And importantly, the other half of going back to the pathophysiology, you have the coagulation end, and then you have the platelet end of things. Once you start to develop that fibrin mesh, platelets are trapped in there, and you start to form these microthrombi. Endothelial damage also causes release of von Willebrand factor, and that's important because you start to form these von Willebrand multimers, which eventually trap those red blood cells, and ADAMS TS13 is another enzyme that's involved. So taken together, forgetting about some of the nitty-gritty that I went over, the thrombosis associated with coronavirus 19 appears to be a low-grade DIC, which also involves pulmonary thrombotic microangiopathy as well. So it's not really full-blown DIC, and we'll get into some of those details. So clinically, there is evidence of platelet-rich prothrombotic deposits in the lungs and other organs. This is what led a lot of researchers to realize that this was starting to look like a DIC picture, but not exactly. As I mentioned a little while ago, there are some distinctions between CAC and DIC. Compared to DIC, elevations in fibrinogen are commonly seen. Now, this is actually the opposite of what you would see with DIC. So when you start to see hypercoagulable state with coronavirus, you're going to start to see increases in fibrinogen along with increases in ferritin and, importantly, D-dimer. This is not the pattern you would see in DIC. DIC, we're seeing suppressed fibrinogen, especially near the hemorrhagic phase, and you're going to see elevations in D-dimer, which is expected. Some patients may have a prolonged PTT, but that may be from consumption of some of the procoagulants. And essentially, CAC is now the accepted term for coronavirus-associated coagulopathy. There's still DIC thrown around in the literature, but at this point, people should be cautious about what they're describing, whether it's CAC or DIC. And why is this crucial? Is it just terminology? Is it just semantics? Not really, because the management of DIC is a little bit different. So as we can go back to the other slide, as we see progression from the left to the right, when patients start to go from non-overt DIC to overt DIC and finally the hemorrhage, the treatment is very different. On the left side, we're really treating the initiating factor, whether it's antibiotics or antiviral agents. When patients start to get into the thrombotic phase, and there is clinical suspicion of thrombosis, anticoagulation use is required if there is no hemorrhagic complication. But as patients start to progress and they become hemorrhagic, the treatment is very different because at that point, you're consuming all your coagulation factors. You're suppressing your fibrinogen levels, von Willebrand factor. The treatment is definitely not anticoagulation. It's actually replenishing these coagulation factors. Fresh frozen plasma, cryoprecipitate are what you would use. And that matters because that is not the problem that's going on in coronavirus-associated coagulopathy. Anticoagulation is seldom used in DIC, as I had mentioned, only if you're really having end organ damage. And interestingly, people tend to be on both sides of the spectrum. In the end stages of DIC, as I had mentioned, bleeding can occur, and it could be attributable to consumption of these coagulation factors. Factor VIII fibrinogen levels can be elevated in these patients. So in some ways, you can think of CAC as an earlier or milder version of DIC, but we should really just be thinking of it as its own phenomenon. It does appear to have a worse prognosis than non-coronavirus associated disseminated intravascular coagulation. One of the first diagnostic studies that clinicians noticed back in January and February was the marked elevations in D-dimer. I mean, they were seeing numbers upwards of 20 to 40 times the upper limit of normal. They were just amazed by this. Other diagnostic abnormalities, they noted the elevated prothrombin time, which can be seen in DIC, obviously. Ferritin levels could be exceedingly high. Platelet suppression occurs, but it's generally very mild. It's nowhere near as severe as what you would see with sepsis in the ICU or severe DIC. And you can still get elevated fibrinogen levels, which is interesting because you are developing these microthrombi, but for whatever reason, they could be very severe. They could kill patients, but they don't really cause these severe consumption of fibrinogen that you would see. And then in one case series of almost 1,100 patients from China, more than 45% of patients were noted to have a D-dimer elevation of greater than 500 nanogram per liter. So as people started to get more interested, they were fortunately able to do some autopsy studies. I mean, these are a little antiquated at this point, but they became very useful in this pandemic. There was an autopsy study of 21 patients out of Switzerland, randomly chosen. 4 of them had a pulmonary embolism, 5 out of 11 with microthrombi, 3 with pulmonary thrombotic microangiopathy. And then in another case series out of Italy, 7 had DVT, and none of these were suspected before the diagnosis. And then let's chat a little bit about ICU patients. There have been numerous ICU case series with several dozen patients showing an incidence of DVT anywhere from 12 to 45%. Obviously, ICU case series are challenging. There's a lot of heterogeneity. It's just a very heterogeneous group of patients. The majority of these patients were on prophylactic anticoagulation to begin with. So it's still interesting that despite that, they were just breaking through with the prophylactic dose. There was also a small DVT screening study in ICU patients, showed nearly 70% DVT incidence. And then a couple of months, about 6 weeks ago, a French guidance paper came out putting all this into context and recommending full therapeutic dose anticoagulation for patients that had increased fibrinogen levels to 8 gram per deciliter or D-dimers greater than 3 microgram per mil. Then in another case series of 183 patients from China, non-survivors had a measurable D-dimer of more than 2,100, while survivors had a mean of 600. In another case series out of Italy, researchers showed that a D-dimer greater than 1,000 at hospital admission resulted in an 18-fold increase in the risk of death. The prothrombin time and thrombocytopenia haven't been shown to be as strong a predictor of poor outcomes compared to D-dimer and fibrinogen. So I think a lot of papers at the moment are focusing on these 2 variables as not only prognostic, but more importantly, predictive biomarkers. Just as a quick review, a prognostic biomarker will tell you what the likelihood of an outcome is. A predictive marker is much harder to hone in on because it tells you that if you make a specific action, an intervention based off a biomarker, what different outcome can you have? So for example, if I was going to design a prospective trial to test the efficacy of a new anticoagulant, for example, and I decide to pick a D-dimer value of greater than 1,000, then I would have to prove that my drug makes a difference for patients that have a D-dimer greater than 1,000 with no evidence of a clot, and compared to patients who have a D-dimer less than 1,000. And then, so going back to these biomarkers, as I mentioned, fibrinogen, if it rises to less than 1,000 nanogram per liter, it's been seen as a harbinger of death in one case series. As you can see, looking at some of these numbers, these are going in the opposite direction of DIC, especially the fibrinogen. In end-stage DIC, reiterating, it really is more of a suppressed phenomenon, not an elevation phenomenon. So let's take a look at one of the largest case series that's been published, just came out a few days ago. So it's the Mount Sinai study. It's one of the largest of its kind. So it was a short retrospective review, short because they gathered this data just over the course of almost 4 weeks, from March 14th until April 11th of 2020. That is just impeccable. Nothing like this has ever happened in medicine in the last 10, 20 years. Just over 2,700 patients with laboratory confirmed coronavirus were in the study. They were all hospitalized at Mount Sinai. Patients were evaluated for the use of anticoagulation, whether it was oral anticoagulant, subcutaneous, intravenous. Data was adjusted for age, sex, BMI, history of hypertension, heart failure, AFib, diabetes, and importantly, prior use of anticoagulant before they came into the hospital. 28% of the patients received systemic anticoagulation. The median hospital duration was 5 days. The median time from admission to anticoagulation initiation was 2 days. I mean, that's pretty good. They initiated a protocol very quick. And the median duration of anticoagulation treatment was 3 days. In-hospital mortality for patients treated with anticoagulation was 22.5%, with a median survival of 21 days. This is compared to 22.8% on immediate survival of 14 days in patients who did not receive anticoagulation. Patients who received anticoagulation were more likely to require invasive mechanical ventilation, 29% versus 8.1%. Now, as we know, correlation is not causation. This does not mean that patients that were anticoagulated ended up on the ventilator. It's just that they were more likely to be sick to begin with, and they already had a higher. One observation was that there was a significant increase in baseline PT, PTT, LDH, ferritin, C-reactive protein, and D-dimer among patients who received in-hospital anticoagulation versus those who did not. For patients that required mechanical ventilation, these differences were not observed. In patients who required mechanical ventilation, the in-hospital mortality was 29%, with a median survival of 21 days for those treated with anticoagulant, versus 62.7% with the median survival of 9 days in patients who did not receive anticoagulation. There was an association between longer duration of anticoagulant treatment and the reduction in the risk of mortality, a hazard ratio of 0.86 per day with a p-value of less than 0.001. Bleeding events were not substantially different, 1.9 versus 3%, with a p-value of 20. But then again, this is not powered to detect a substantial difference in bleeding event. It was again a retrospective review. Patients that did not have bleeding events, 37% already had one. For patients that had a bleeding event, 37% already had one prior to the initiation of anticoagulation. The association between anticoagulant use and mechanical ventilation is likely related to underlying disease severity, as I had mentioned earlier. And here's some of the data. In red, we have no in-hospital anticoagulation. And in blue, we have patients that received treatment dose anticoagulation. On the left, we have a very clean separation of the curves over 2,700 patients. And you can just see that real clean delineation. And on the right-hand side, we have patients that required mechanical ventilation, 395 patients. And you could see the profound difference. For outpatients, primary and hospital discharges, the DVT incidence appears to be much lower than in non-ICU patients. For outpatient management, patients who are admitted for CV-19 should be discharged with prophylactic low molecular weight heparin for at least a month. No data to support the use of Coumadin, no data to support the use of NOACs. A month is generally recommended, though this is not a robust recommendation. It appears to just be anecdotal from experts. And it's actually very common in a variety of other settings, whether patients have hip fractures or sometimes patients that have blood clots during pregnancy. They will definitely use these for a month after being discharged. Non-hospitalized patients with mild coronavirus, they don't need anticoagulation. How can we put all this together in a useful fashion for clinicians? So from a lot of the society's guidelines, every single suspected case and confirmed case of coronavirus should get a thrombosis panel. At a bare minimum, you should order a DIC panel, PT, PTT, obviously a CBC, fibrinogen, D-dimer. You can also consider a ferritin, LDH level. Some people might throw in a factor VIII level. CRP, I mean, these are just going to start to give you a general picture of an inflammatory state. But as far as picking the variables that you might act on, it's really going to be fibrinogen and D-dimer. I would definitely have these labs checked on admission, keep a very low index of suspicion to recheck these. The recommendation is every 2 to 3 days, but these patients can decompensate quickly, and it's like an avalanche. You'll have exponential deterioration. The sooner you act, time is your enemy. So the constellation of findings of an elevated D-dimer and a prothrombin time, along with suppressed fibrinogen and platelets, should prompt close monitoring for signs of thrombosis. Now, again, the majority of my conversation is focused on venous thromboembolism. If there's any suspicion of arterial thromboembolic phenomenon, whether it's mesenteric ischemia, which is less common, limb ischemia, myocardial infarction, stroke, I mean, that is a different conversation in and of itself, but they are predisposed. What does all this mean clinically? So again, as I had mentioned earlier, many case series have shown that there's an increased mortality associated with not only DVTs and arterial thromboembolism, but also they're calling into question new guidelines for anticoagulant prophylaxis. One case series from China with more than 400 patients showed a greater than 20% reduction in mortality in patients given just prophylactic anticoagulant versus those who were not given prophylactic doses. So this begs the question, what other important questions should we be asking? Should all patients be placed on anticoagulant prophylaxis? Yes. The consensus appears to be a solid yes, unless there's an obvious contraindication, an active bleed at the moment. Is low molecular weight heparin or unfractionated heparin preferable? Low molecular weight heparin, and I'll explain why. While it doesn't have the anti-inflammatory effects that have been reported with unfractionated heparin, it does offer a convenient dosing regimen for nurses. It's a single subcutaneous injection a day versus 3. And at a time where PPEs are scarce, you're going to be hard pressed to go through several sets of PPEs just to give a heparin injection. It's just, and at the end of the day, it is a little bit less burdensome on a patient as well. And it's something that they can go home on. They will not be going home on unfractionated heparin injections that they give themselves 3 times a day. The elephant in the room is therapeutic dose anticoagulation. Should full dose therapeutic dose anticoagulation be used in patients who develop severe CV19? And the question by some other experts in the field is, do they even need to have severe CV19 if we decide to initiate full dose anticoagulation? It remains a contentious issue, and I'll go over some of the major societies' guidelines. And let's start with just a couple of papers. I've referenced these in the back. For example, this was a publication that came out of France. It's 150 coronavirus COVID-19 patients, and the recommendations by the ICU team was that higher anticoagulation targets, as you can see from the arrow, and in the usual critically ill patients should be suggested, should be considered. Another paper by Clock, again, another ICU team making the same recommendations. So there was a big push in the ICU community, more so than in the hematology community, to treat with therapeutic doses of anticoagulant. So let's see what some of the societies have to say. This is ASH, the American Society of Hematology, and their consensus was whether critically ill COVID-19 patients should receive therapeutic intensity anticoagulation in the absence of confirmed or suspected venous thromboembolism is currently unknown. Some have questioned the validity of this conclusion in the midst of a pandemic. I think some people were angry at ASH for not having a more aggressive stance, but I think they were trying to be as judicious as possible because there are significant concerns with full dose anticoagulation in patients that have multi-organ dysfunction. If patients are going to have complications of diffuse alveolar hemorrhage, for example, and they're on full dose treatment dose heparin, it could be a nightmare. And then more commentary, the question was, what are the risks and benefits of empiric therapeutic anticoagulation in COVID-19 patients? And again, they highlight the fact, however, this remains controversial because the true incidence of PEDVT in patients receiving pharmacologic thromboprophylaxis remains uncertain, and data to show improved outcomes with therapeutic anticoagulation is lacking. So I think until we have robust phase 3 clinical trials showing improved outcomes with therapeutic dose anticoagulation with at least a couple of easily reproducible biomarkers, the American Society of Hematology will not take an aggressive stance. The American Society of Clinical Oncology also mirrors the same sentiments. At this moment, while practitioners use a variety of prophylactic, intermediate, or therapeutic doses of anticoagulation in patients, the optimal dosing in patients with severe COVID-19 remains unknown and warrants further prospective investigation. This intermediate dose anticoagulation has come up. It really never existed before COVID-19. The spectrum is unfortunately generally about fourfold. Low molecular weight heparin, Lovenox, for example, you're giving 40 milligrams subcutaneous daily. The treatment dose is going to be 1 milligram per kilogram every 12 hours. So an average person in America, we use 70 kilograms. So that's going to come out to 140 milligrams a day. So 40 milligram versus 140, you're almost at a 4x difference, and it's higher for heavier people. So intermediate would be somewhere in between, but there's literally no data in this intermediate range. I think it's just some arbitrary junction point. And then the American College of Cardiology, again, should therapeutic anticoagulation be used in patients with COVID-19 absent confirmed or suspected thrombosis? And they comment, there is substantial controversy about the use of escalated dose of anticoagulants to prevent thrombotic events in COVID-19. Some have advocated that anticoagulants may help prevent other complications, such as respiratory deterioration and mechanical ventilation due to pulmonary vascular thrombosis. However, because therapeutic anticoagulation is also associated with an increased risk of bleeding, it should ideally be used in the context of a randomized trial for prevention of thrombosis based on our current state of knowledge. Some final thoughts. As I had mentioned earlier, maintain a high index of suspicion for thrombosis in patients with suspected coronavirus. Obviously, same clinical judgment, it's not any different. Lower extremity swelling, pain, erythema, tenderness, warmth, ultrasound. I would have a super low index of suspicion for an ultrasound. If patients have proper kidney function, while it may be hard to determine an acute on chronic change in breathing when they're already having trouble breathing, if their kidneys can handle it, I would definitely get a CTPA and rule out a pulmonary embolism. Check hypercoagulable markers every 2 to 3 days. I would even say every 2 days. It's really not a big deal. D-dimer, fibrinogen, PT, PTT, CBC at a bare minimum. As I had mentioned earlier, consider ferritin levels, consider factor VIII levels as well. CRP will probably be thrown in at some point. All patients should receive prophylactic dose low molecular weight heparin. You can consider unfractionated heparin unless there's some major contraindication, such as bleeding. Strong consideration should be given to increase the dose to intermediate if one can make a case for themselves, and then a therapeutic dose if patients decompensate clinically or show elevations in D-dimer or fibrinogen. Close monitoring for arterial thromboembolism as well. While it's rare, again, you can have devastating consequences, but I will defer to cardiology, neurology, and vascular colleagues for that. And ultimately, God willing, if patients are discharged from the hospital, they should go home on low molecular weight heparin injections for at least a month. Warfarin, novel oral anticoagulants, just not recommended at this time. And the last thought, an ounce of prevention is worth a pound of cure. So just maintain a very low index of suspicion. It is really an avalanche phenomenon. The snow's already packed on top of the mountain. You don't want that sucker to get out of control. Just as much preventive care as can be done as possible to spare the downstream complications of significant thrombosis. It can be a one-way door, and you don't want to go through that door. Okay, I'll take some questions.
Armin, thank you very much for that very informative and concise lecture on hypercoagulability that as we're seeing in COVID-19. If you can stop sharing your screen so that the people asking questions, that I'm going to ask Dr. Apelian, Rami, there you are, to moderate the question and answer session, please.
Thank you, Dr. Sapilian, and thank you to Dr. Sarkissian. I actually found your conversation today to be very relevant. However, a lot of the questions that we had come in are differentiating between venous and arterial coagulopathies. We've heard stories about young individuals who have lost limbs or young individuals who have no medical comorbidities, suffering strokes. Do we have an explanation based on the information that you provided as to why this is happening?
You know, it's obviously much rarer than this CAC picture that I've described, but there have been reports of lupus anticoagulant developing in these patients. And much more than some of the other predisposing conditions for DVT, whether it's protein C and S deficiency, factor V laden, antithrombin deficiency, prothrombin deficiency, lupus anticoagulant does have a propensity to form arterial clots. Obviously, strokes, heart attacks, and peripheral arterial disease. It's probably a similar mechanism. The treatment ends up being a little bit different because obviously in the arterial realm, antiplatelet agents are the mainstay, whether it's going to be Plavix, aspirin, some lesser role for dipyridamole. But that's obviously a conversation for the neurologist.
I mean, hey, I'm a neurologist. I'm just trying to create the conversation, you know?
Yeah.
But at the same time,
antiplatelet agents don't have as much of a role on the venous side of things because the trouble is definitely more in the coagulation cascade.
And I mean, I get that. At the same token, we're seeing young patients who don't have the medical comorbidities suffering very significant arterial consequences. I mean, in the media, we've heard about the EMT in New York who, you know, died of, unfortunately, cerebellar and cortical strokes. We've heard about the Broadway and Disney actor who lost his limb because of the arterial aspect. I mean, you mentioned IL-6. IL-6 has been thought to be a weak cytokine, but it's actually really important in the complement cascade. And some of the inflammatory aspect of this disease has been associated with complement. Is that perhaps a contributory cause on the arterial side? Do you have any thoughts?
Yeah, actually, you know, the complement cascade has come up as a target in sepsis, actually. While it has roles in the immune system, obviously, the actual, a lot of drug companies have tried to target it as part of treating sepsis. I mean, nothing has really come of it like they were planning during the last 10 or 15 years, but yeah, it still remains pretty unknown.
I mean, I think that's an important thing to emphasize, is there are so many aspects to this disease that are unknown. I mean, we're actually figuring it out as we go along. From the United States standpoint, we've only been dealing with this for about 2 months. The whole world has been dealing with this for about 6 months. And every day, as you mentioned, the medical literature opens up with more transparency, even before publication. That said, one of the questions we had come in from our leadership, Dr. Barkudarian, asks, the cytokine storm, how does the CAC associate temporally with the cytokine storm that we have all heard is associated with COVID-19? And are they related? Are they not?
No, I think they're definitely related. I mean, obviously there's the There's sort of the more popular cytokines that people talk about, tumor necrosis factor alpha, interleukin-1, interleukin-6. There's probably some uncharacterized ones and less well-studied ones, but those are going to be the inciting factors. So, the monocytes are going to release some of this TNF alpha. There's going to activate endothelial cells. So the cascade does start with the cytokines.
Thank you.
Yeah, and I think my one interesting thing I've noticed is that while there is a lot of talk on tocilizumab, and I've read a lot of, not all the papers, obviously, I've read a fair amount that's come out, but it seems to be that they're using it later than earlier. I could be wrong. What's been your general impression as to when most places are pulling the trigger on TOSI?
I actually don't have a whole lot of experience with TOSI. And I can't comment on my understanding of this. I mean, everything changes literally day to day. I know a lot of the companies that work on complement in the neurological sphere, as well as work on interleukin mediation of MS, are looking at whether or not they can reduce the inflammatory response in COVID-19, but we just don't have the data. And I mean, I think that's
like eculizumab, correct? That targets
absolutely.
C5a. Yeah, because that was later approved for myasthenia, like you mentioned.
Right. And I mean, I think one of the challenges simply is that we don't have enough data. And anything at this point is speculative, particularly with monoclonal antibodies. That said, we've heard about COVID toes. We've heard about various other indicators now that COVID has become more prevalent. Do you think the COVID toes is an ischemic issue? Is it a vasculitic issue?
I have a feeling it's more of an ischemic issue. Because if you look at the sheer number of people that are developing DVTs and PEs, whether it's from autopsy studies or screening studies, I mean, when you're starting to go upwards of 20, 30, even 40%, obviously ICU patients are very, very heterogeneous, but compared to a background incidence of on the order of 5%, I mean, I'm not saying it's hopping over the fence, but it's a very ischemic phenomenon that's developing. It's probably more that than vasculitis.
I mean, I think that's the challenge, is that I think we're trying to understand whether this is vasculitic or venous versus arterial ischemic. I mean, if you had a hypercoagulable state that affected both the venous system and the arterial system, that could mimic a vasculitic state as well. And I mean, we just don't know.
No.
And I mean, the guidelines that you provided today in your lecture based on societal recommendations are great for the venous side, but we really actually have no recommendations for the arterial side. And while antiplatelet typically is the mainstay of therapy on the arterial side, how do we balance that? I mean, we don't. I mean, I'm not posing that question for you to answer. I mean, this is a question for medicine in general.
No, it remains challenging, and I've even in our own hospital, I was the covering medical director because our medical director was on leave, and I was asked to put together a pamphlet, and I reviewed all the society guidelines that I mentioned here. I put together the packet, and I was actually recommending something more aggressive. I was making a case to really consider therapeutic dose anticoagulation early on, as long as there are no major indicators of bleeding. But that got vetoed. Not every practitioner wanted to be as aggressive. But hindsight is 2020. When these patients, they might look fine on the floor for a few days, but once they get out of control, you can't turn the hands of time backwards.
I mean, I think you raise a really good point, and this is something we hear from clinicians that are on the front lines time and time again. Everything is okay until it's not okay. And when it goes not okay, it goes not okay very, very quickly. And you have to make a decision clinically. Because if you make no decision, the patient's going to decompensate. The outcome is obvious. So, you have to make a decision quickly, and there are no guidelines under those emergency circumstances right now.
Yeah, it really is the Wild West. And, as much as we look to the guidelines, the societies for their guidelines, they do remain political organizations. I'm not saying political like Republican or Democrat or anything like that, but they're trying to be as judicious as possible, balancing risks and benefits. But at the end of the day, like the doctors are the ones in the trenches with a patient looking at them.
No, you're absolutely right. I saw an article, I don't know if it was in the LA Times or the New York Times, about a pulmonary critical care physician who just decided, because of the clinical picture, he couldn't fit the patient's symptoms and the laboratory findings into an obvious diagnostic status. He couldn't put it on one diagnosis, so he decided to give the patient TPA. Well, turns out the patient actually was hypercoagulable on an arterial state. The patient wins, and this makes national news. And I think the challenge is that you're right. I mean, we don't understand this disease state. We are all, fighting this as best we can. We have guidelines, but these guidelines do not necessarily apply to each individual patient.
Yeah, and like I was mentioning, I mean, you end up staring at a patient. You have some diagnostic studies, you have some crude metrics. You can't get a CT scan of their chest every single day. You're just kind of going off hypoxia, their respiratory rate, physical exam, and we tend to have a habit of just checking on them daily, but a day is 24 hours. That might be a lot of time for coronavirus to just get exponentially worse.
And so that leads me to the next aspect. I mean, you mentioned the conversation about, checking every 48 hours, the hypercoagulable aspect, but the fact that these patients can decompensate quickly, why not do it in a shorter time frame?
I think they're trying to also minimize blood draws on some of these patients, because it does end up being a decent amount of blood that's taken out when you order so many tests. So if someone's going to be there for a week and you make them iatrogenically anemic along with other complications, I think they also don't want practitioners to overreact. If they don't want them to get trigger happy or overwhelm them with variables. That could be one reason. So,
I mean, you mentioned the role of NOACs.
Yeah.
I want to encourage you, before I move on to the next question, to define what an NOAC is, and then ask you, you mentioned low molecular weight heparin injections as a possible long-term 30-day anticoagulant source. Or anticoagulant treatment for our patients, but assuming patients don't want to do that, are there other alternatives, and how do you monitor those patients?
Yeah, just as a review, the NOACs are novel oral anticoagulants. So for about 40 or 50 some odd years, we had warfarin. And if you're a real nerd, it just stands for the Wisconsin Alumni Research Foundation, Coumarin. That's where the name came from. So it's really the mainstay of anybody with a blood clot, anybody with atrial fibrillation, kind of a pain in the butt to do INR monitoring, watch your diet, tell your doctor if you have to take antibiotics. So about 15 years ago, they started developing these agents that don't require laboratory monitoring. There are the direct thrombin inhibitors like dabigatran, I think Pradaxa is the brand name. And then there are the factor 10 inhibitors, rivaroxaban, apixaban, and a couple of other agents. Some of them are not available in the US, like they're available in Japan. But long story short, easier to take, no diet modifications, no laboratory monitoring. There is a small caveat of rare but irreversible bleeding that occurs, less than 1%, but there is an antibody associated with it. So interestingly, while it did make life easier for patients that had blood clots and atrial fibrillation, it did not really pan out in some other unique niches of the thrombosis world. Importantly, the lupus anticoagulant patients. there have been mixed studies about whether or not these patients can take a drug like rivaroxaban or apixaban and still maintain the lowered thrombotic propensity, I guess I should say. And there have been mixed studies. Some patients with lupus anticoagulant have actually done worse on these drugs, and not like a case series of 10 patients, somewhere on the order of 100 patients. So while you are targeting a downstream protein in the clotting cascade, it just teaches us that it's not just the way it looks on the chalkboard when you draw it out. The pathophysiology can be a little bit more complex. So while a lot of us do want to make the lifestyle better for the patient, we also don't want them to have inferior outcomes. So I think with that being said, it's really the the anti-inflammatory effects, I should say, of heparin that that helped it find a role in this. It also happens to be a much more common anti-prophylaxis drug than aspirin or rivaroxaban in the hospital. So those two factors just kind of dovetailed nicely on top of each other.
No, I mean, I understand that, but at the same token, these novel oral anticoagulants, there's no data to support their use.
No,
but we've used them off-label under various other hypercoagulable states too.
Yeah, but I think at this point, especially with a sicker patient, probably best to not use it. While it is annoying for a patient to have to inject themselves with heparin or what's the other one, dalteparin at home, it's only about a month. You don't want any sort of weird effects happening with these novel agents, even though it's going to be burdensome to the patient.
So any comments about how the use of convalescent plasma or, immune globulin from patients who have been exposed may reduce the risk of hypercoagulability?
I don't think there's much data on that. But I think it's always going to be a risk whenever you're introducing an agent like that. There's always going to be a risk of a thrombotic event. So it's always something to keep in the back of our mind.
I mean, I know we're focusing on thrombosis at this point, but do you have any comments regarding the changes in hemoglobin itself and the oxygen carrying capacity affecting the hypoxia associated with the COVID-19 pulmonary response?
Yeah, there was actually this, not a trial, but a couple of Chinese researchers had sequenced the novel coronavirus genome, and they had done some of the protein crystallography predictions based off of predictive folding patterns. And they did see that it does actually fit one of the grooves in hemoglobin. So I'm not sure if there's been robust data validating that, but there is some possible interaction in the hemoglobin molecule itself. I don't remember if it was on the alpha chain or the beta chain, but there is some interaction there.
No, and I mean, I think that's one of the reasons that we don't have data, truthfully, about the appropriate use of any anticoagulant in this setting. Do you have any recommendations as far as the dosing of Lovenox? Let's say you had a patient with a D-dimer less than 1.
Mm-hmm.
And hold on, I lost the question. Bear with me.
While Dr. Apelian is...
here we go. Sorry. Go ahead, Viken, please.
Yeah, go ahead. Finish. Go ahead.
No, so you have a D-dimer less than 1, but still greater than 3 based on mg per kg. What do you do?
So say it again. So D-dimer less than 1, but
still greater than 3 based on their weight-based dosing.
I'd probably advocate for intermediate dose. Now, assuming obviously there's no risk of bleeding, but I would keep a pretty high threshold and keep monitoring that every couple of days. Also keeping in context what their respiratory status is like, both as far as oxygenation. Do they require supplemental oxygen? What's their respiratory rate? But, you know, honestly, I mean, the bleeding rate with prophylactic low molecular weight heparin is so low. I mean, even the doses that we're using are the end product of very conservative clinical trials. So there's such a low bleeding risk to begin with. Even for patients that are on Lovenox, they do all kinds of stuff that they're not supposed to be doing, right? You know, there's like millions of people on Coumadin or Xarelto, and I don't think they're completely avoiding playing sports or, you know, working on a ladder and falling down, and they don't all come in with bleeds. So even though it does technically predispose you to bleeding, it's not really
In an
as
emergency situation, I'm sorry, like,
yeah,
you
yeah,
do what you can to save a life.
yeah.
You deal with the bleeding later. I mean, that's my philosophy in an
That's
emergency
our philosophy
situation.
too.
I
You're
mean,
not bleeding until
as a
there's
neurologist, I deal with strokes, right? You administer the thrombolytic, you administer the drug that dissolves the clot, hoping to save a life. The outcome could be negative, but then we'll deal with the bleeding later. And that's just my perspective as a neurologist. I'm willing to hear your thoughts.
Yeah, we have that same attitude too. The only time you stop a blood thinner is when you have proof of bleeding. There has to be some proof of bleeding, not you're going to bleed a year from now or a 2% chance over the next 5 years. It's, do you have a bleed right now? Yes, no? Okay, you go on a blood thinner.
Yeah. Dr. Sarkissian, thank you again for this talk. And there we have some questions that are coming in from Facebook. And
Yeah.
again, some of these questions are, you know, from our healthcare colleagues, but some are just from interested individuals who are, you know, who happen to be watching. And you know, as you had mentioned earlier on, that you're, you know, in addition to being a hematologist, which is a doctor who takes care of blood disorders and clotting issues and so on, you're also an oncologist, which is a cancer specialist. And I'd like to just take a, you know, pivot from our hypercoagulability talk today and ask what's going on in terms of your everyday oncology patients who are in need of chemotherapy, who may be in the middle of their treatment, their cancer treatment, having it be a type of treatment that may need it to be administered in the office or in a some sort of a non-home setting. What are some of the guidelines, or what are some of the things that cancer practices like yours are doing to, I guess, continue these potentially life-saving treatments, albeit at a, you know, at a safe manner?
Yeah, that's a really good question. You know, while there are a few hundred different types of chemotherapy regimens, I generally break them down into low, intermediate, and high risk of myelosuppression. There's really only a couple of rare conditions in which you're going to get very myelosuppressive chemotherapy. The most extreme are going to be transplant patients, patients getting auto transplant for, say, myeloma, recurrent germ cell tumor. Those are going to be in transplant centers. And at the moment, they are off. I mean, unless you're going to go to a very remote state, like in Minnesota or somewhere, they might be doing them there, but City of Hope has stopped. So have allogeneics. And then in the more common outpatient setting, leukemia treatment is going to be very myelosuppressive. You know, somebody will become aplastic on the order of about 10 days. I'm talking, you have a white count of completely zero, zilch, and you're just living off blood and platelet transfusions, hoping your leukemia is eradicated, your healthier marrow comes back. But during that 10-day period, especially if you're older, you are fair game to everything. Gram-negative bacteremia, CMV infections, fungal infections. And if you pick up CV-19 during that time, it can be very bad. I mean, you don't have any immune system to fight off the effects of coronavirus. So it is, God forbid, a bad time to end up with AML. Not that it was ever a good time, but it's a worse time. Same thing with ALL. You know, the other hematologic malignancies, again, very similar. If you're getting treated for lymphoma, diffuse large B cell, Burkitt lymphoma, you are going to require myelosuppressive therapy. It's not as severe, But again, lymphomas, again, not as common. Now, some of your more common cancers, so for example, breast cancer, again, it's exceedingly common. Whether it's going to be chemo in the neoadjuvant setting or adjuvant, as in before or after surgery, yes, you are going to get myelosuppressed. And unfortunately, we do have to give that chemo in a timely manner as soon as we can after surgery or right before. It's not something that we can delay 1 or 2 years out until, God willing, the pandemic is resolved. So those are the more challenging patients. The cancers that are common and where you are in a time crunch to treat these patients appropriately. So breast cancer, as I mentioned, is a good example. What we do for these patients, you first risk stratify them, essentially by age and comorbidities. So if you're 70, 75 years old, you have a new diagnosis of breast cancer, yeah, we want to give you everything possible, but you're going to have a higher risk of a neutropenic complication compared to, say, a 50-year-old. So that at that point ends up being a case-by-case conversation. You tell the patient, these are the risks. We'll try and modify the logistics of the infusion center where you maybe get your own private room, it's desanitized. We make sure everybody coming into the infusion center has a temperature check, respiratory check, and actually starting at our clinic, we are going to require coronavirus testing within a 72-hour window before they come to the infusion center. So there have been a lot of safeguards put into place. But as much as we can do, I mean, unfortunately, it's a big misfortune to have cancer during this time. And for the very few patients that do require very, very myelosuppressive therapy, they may just have to weather the storm and take the risk. Now, a lot of people do wonder, is there a role for antibacterial agents and importantly, antiviral agents? That has been a contentious issue in the literature for years. So, we'll see. I mean, with remdesivir approved, there might be a role for prophylactic use for patients undergoing myelosuppressive chemotherapy. I think it would be a worthwhile study to do. The last thing you want to do is get a nasty CV-19 infection when you're trying to cure yourself of cancer. So, really important questions.
No, I mean, I agree with you, Dr. Sarkissian, and I think one of the things about an infusion center that you address as a concern are obviously very much concerning thoughts to us as referral sources as well. The challenge I think we all face is the private versus a public setting for an infusion center. I mean, I think in the COVID-19 era, we are all talking about keeping ourselves separated, but also keeping our patients separated during an infusion, particularly one that lasts multiple hours. So, I mean, I thank you for those comments. I mean, I think those are all very appropriate, not just in the chemo sphere, but in other disease states, rheumatologic and neurologic as well.
Yeah, I think when the pandemic was rip-roaring in New York about a month ago, I mean, I was in a small minority of people advocating for outdoor hospitals. I mean, some of the worst things that happen, unfortunately, are these air circulatory systems. They weren't designed to vent out every coronavirus particle. So, I mean, I don't think anybody's going to be developing outdoor infusion centers, but at the end of the day, having a few patients with an infection confined, working with healthcare practitioners that go from patient to patient, I mean, that was one of the biggest problems in New York, was having all those people with healthcare providers that are treating multiple patients all in the same room. I mean, it is what it is, but that's why with infusion centers, they've really started spacing patients out.
I couldn't agree with you more. And I think one of the challenges that we're all facing is that, I mean, we're all used to providing healthcare indoors. And there's been years, decades of data that demonstrate that coronavirus, specifically a mutatable virus, one that can change minute to minute, does not do well in an outdoor setting with high ventilation. So, I mean, you're introducing a very interesting point that is definitely medically validated.
Yeah, Dr. Sarkissian, there was a specific question that came through about somebody who was recently diagnosed with MDS, which is myelodysplastic syndrome. And
Yeah.
I guess that can potentially fall under one of those categories where they could have, they may need a bone marrow transplant. And are there any guidelines on or guidance on what practitioners or patients in that category should be doing?
Yeah, you know, MDS is a very interesting disease because you get a really wide spectrum. You get some people that die of it and some people that die with it. Transplant is technically the answer for a myelodysplastic syndrome if they have high risk features and the patient is expected to live for at least another, I would say, on the order of 10 years plus. You know, if their life expectancy is on the order of 5 years, then a transplant is definitely not in question. So an example would be if somebody has intermediate grade MDS and they're 60 years old, they're in good shape, or even high risk MDS, they should be considered for an allogeneic stem cell transplant, because if it wasn't for MDS, they'd have a life expectancy of at least 20 years. So that's a challenging case. But the one advantage to having MDS that may require a transplant versus overt AML is that you can buy yourself time. There will be a year by year transformation rate to AML depending on where you are. There's a scoring system for what percentage of your bone marrow is composed of blasts, leukemic blasts. So if you have only like 5 or 10% blasts, then yeah, you could probably get by another year or two until you transform to AML. But once you're in the 10 to 20% range, I mean, the evolution of AML is very likely over the course of the next year. So now, in the context of coronavirus, I mean, yes, we're at sort of the peak of the pandemic in certain parts. I mean, we're really recovering in New York. If there's any time to get a transplant before another spike in the fall, I think the summertime would be it, to be honest. And you may even consider getting, if you need a transplant, first of all, I'm thinking of the worst case scenario, you may consider going somewhere like a state that has a robust transplant program, but low overall COVID numbers.
Right. I believe this question is coming from someone internationally. However, that's great input. Thank you for taking that.
Yeah.
There's also some questions that have come through regarding pregnancy. As we all know, or as some of us know, pregnancy is considered as one of these hypercoagulable state. And for those of you who are watching on Facebook or who are not in healthcare, that's a state where the blood tends to clot more readily than usual. So, as you so elegantly presented on some of the findings that we've begun to understand with COVID-19, is there any guidance on how pregnant women should be handled who have been diagnosed with COVID-19 as it pertains to hypercoagulability?
Yeah, I think the recommendations are not as strong because it's a smaller subset of patients with less data available. I was looking at one case series where a lot of even some of the pregnant patients that ended up having severe COVID-19, they were able to deliver in their third trimester and none of them had died. But I think the recommendations are going to be very similar to patients that develop blood clots during pregnancy or postpartum. It's always going to be low molecular weight heparin preferred over Coumadin. That's never going to be the right answer. Same thing with NOACs. Now, whether somebody should pick a prophylactic dose versus a treatment dose in the absence of a confirmed blood clot, I think that's going to be a very challenging case-by-case scenario because there's plenty of other variables that one has to consider with a pregnant patient. Especially if it's like a high-risk pregnancy.
Of course, yeah. Now, in regards to antiphospholipid syndrome, what are your thoughts on some of the hypercoagulable issues that we're seeing, it being due to an acquired antiphospholipid syndrome or an underlying antiphospholipid syndrome that was never picked up and hence as a result of an infection with COVID-19, it being coming to the surface.
Yeah, I think that would be a very challenging scenario. So with the antiphospholipid syndrome, we do follow the Sapporo criteria, where we really need to repeat the test and show repeat positivity at a minimum of 12 weeks, apart from between the initial diagnosis and repeat tests. The standard of care is to use Coumadin. So in these cases, I think people are doing different things. I think some people are sticking with a heparin approach or low molecular weight heparin, and some people are transitioning to Coumadin. It really is not a one size fits all, unfortunately. It really depends on the patient scenario. I mean, are they mildly symptomatic and you think they can comfortably go home? Then you can probably bridge them with low molecular weight heparin and then put them on Coumadin if they're out of the hospital. It's different if that's positive and they have an arterial clot, God forbid, and they're in the ICU. Then you're probably stuck balancing maybe an antiplatelet agent and an anticoagulant like heparin. Then you start to get, very complex. So then you have the crossroads of, do you pick Coumadin to treat the lupus anticoagulant? Do you try and target the prothrombotic state of the COVID-19 with an anticoagulant like heparin? And then how do you treat the arterial phenomenon if it's there with an antiplatelet agent? So.
Yeah, very, very interesting, very interesting and challenging dilemmas that, us healthcare professionals are being faced with these days. However, this is what we go through our training and specialize for. And the innovations and scientific research is truly helping us understand the pathophysiology better, so we can best care for our patients. And really, we're very thankful, Dr. Sarkissian, for that a wonderful presentation where you presented data from all over the world, and the medical literature has been so collaborative between some of the evidence that you shared that came from China, some of it that came from Europe, from the East Coast, the United States, and New York, where obviously New York has been the epicenter of the world. It really is, it's really great to learn from each other's experiences. And fortunately, here on the West Coast in California, we have been able to keep things in moderation, to some degree being grateful from our colleagues who have shared their experiences in other parts of the world, so we can learn and best care for our patients. Let me check just to make sure that we addressed all the questions. There was one comment or a question if there are any non-pharmacologic ways of achieving anticoagulation at home. Is there anything like that is that is medically approved?
No, I mean, I think there is a lot of anecdotal data from random herbs and things like that that supposedly thin the blood, but you have to look at how you would, quote unquote, thin the blood, achieve therapeutic dose anticoagulation based off the tests that we have available. Going back, 70 years, we had the classic bleeding time. Not a lot of people do that anymore. We have euglobulin lysis times. We have the prothrombin time. We have the activated partial thromboplastin time. We have a variety of tests. There's probably there's platelet electrothrombographies. There's probably a smattering of maybe 10 total tests. Your PT, PTT, fibrinogen, platelet counts are going to be your 4 most common ways of determining if somebody is at a risk for bleeding. Does somebody have thrombocytopenia? Do they have elevated PT, PTT? Do they have suppressed fibrinogen levels? Those 4 will answer, 99% of your questions. The other ones are just more subtle differentiating features. So as far as sort of allopathic treatments to thin your blood, I think it's just really anecdotal, unverified information that's out there.
Thank you for that. I think it looks like we got to all of our questions. I just want to take this, opportunity, Dr. Sarkissian, to truly thank you for taking the time.
No, thank you. I appreciate the opportunity. Hopefully people learned a lot.
Yes, definitely. I mean, as we've been hearing, and as we saw, there is a lot that is unknown about this condition, and we're learning. However, there also is a lot that we do know about pathophysiology of diseases in general, and it is exactly these types of exercises where we bring multidisciplinary specialists like you, who are on the forefront of your field, who are on the forefront of the latest medical evidence as it pertains to managing patients with COVID-19 and clotting issues that they're experiencing. This is how we get to learn, and we truly advance our ability to best care for our patients. And we're very appreciative for taking your time and and sharing this. We'll look forward to inviting you again and for having some updates as we learn more on this, not just as it pertains to blood conditions, but as well as cancer issues. Again, and I'd also like to thank all of the organizers, our CME committee, Continuing Medical Education Committee, our board members, and as well as our audience. Everyone out there who's watching, please feel free to give us feedback. Please feel free to visit our website, aamsc.org, where you'll see a tab for the webinars, and you can watch all the archived episodes that we've had. Thus far, we've had more than 20. And if you do want to claim CME credits, please, you can also go to the website, engage in the CME activities, and take the post-event quiz, and you can claim your credits. With that, Dr. Sarkissian, again, thank you very much.
Of course, thank you. Appreciate it. We're looking forward to round 2.
All right, great. We'll look forward to that. Ladies and gentlemen, have a great evening. We'll be back tomorrow night. Tomorrow we'll be talking about some practical issues as it pertains to the practice of healthcare or any other professional practices for that matter. Arababayan, who's an attorney from the Armenian Bar Association, will be presenting on the Paycheck Protection Program that was launched by the government, as well as some other business and real estate issues as it pertains to the practice of medicine. We will also have Sev Araradian, who's a banker who knows the nuances of the PPP from a SBA banker point of view. And we'll be discussing some of the nuances of what the government has given us as it pertains to the relief and our employees, ourselves, and our practices. So please join us tomorrow at 7 p.m. Pacific time. We'll see you then. Have a great night, everybody. Thank you.
Good night.